is Germán David Ospina. I am specialist in human reproduction, and I am the medical director of INSER Bogotá. Okay, first of all, it's a real pleasure for me to be with you today, and we talk about a very interesting topic in human reproduction, and is refractory endometrium. And this is a difficult situation in a regular patient when the endometrium doesn't respond to the usual medication that we are taking in a normal treatment of reproduction. Okay, then refractory endometrium, this is our topic of today. And first of all, I want to give you my point of view. This is a personal view about what are the factors that we need for achieving a pregnancy. The first factor is the eggs. We need a good quality and quantity of eggs. You know that from many years ago. The second factor are the sperms. We need a good quantity and a good quality of sperms. Third, we need a healthy woman. And finally, we need a good endometrium. And this is the guest star of today, the endo. Okay, then I was to tell you before, the endometrium is a very important structure for the implantation of the embryo. But before to go in the central point of my lecture, I want to give you two important concepts about the endometrial receptivity, the window of implantation, and the implantation as such. First of all, the endometrial receptivity is a temporary, unique sequence of events and factors that allows the embryonic implantation. We know that from many years ago, but also this receptivity is a little window of time when the uterine environment is conducive to blastocyst acceptance and subsequent implantation. The endometrium allows the attachment of the embryo to the endometrial epithelial cells and the endovascular trophoblast invasion. Okay, all of this process need the action of the hormones. The main hormones that are involved in this process are estrogens and progesterone. In the first part of the cycle, the estrogens are rising and proliferating the endometrium. And after that, the progesterone will open the window of implantation. And there is a lot of factors, and especially I want to remember two special molecules that are very important in the process of implantation. The first one is the COX-2, and the second one is the cytokines. Both of these factors maybe are the most important factors that we need for having a good implantation. Okay, and what is window of implantation? This phenomenon occurs between 19 to 20 days of the menstrual cycle in women with regular bleeding. It's a cascade of complex synchronous molecular interactions between the embryonic trophoectoderm, the endometrial surface, and the endometrial glandular epithelium. The exposure to progesterone synthesized by the corpus luteum allows the embryo its apposition and addition. If you see here in this picture, the window of implantation is a very short time, and usually this window open 5 days after the ovulation. But sometimes there are women with different moments for the window of implantation. This is not the central point of today, but it's just information maybe useful for you. Okay, and finally, the implantation is a complex, because you know all of this process of the implantation of the embryo is a complex series of development in this case, starting from blastocyst hatching and attachment to the endometrium until the formation of the placenta. The steps start from apposition and progress through adhesion and invasion. The clinical implantation in human species is efficient in a maximum of 30% of cases. If you compare these numbers with other species of mammals, obviously we are very low in this comparison. In my opinion, we are a very inefficient species for the reproduction. And the implantation failure remains a major challenge in IVF process. And I believe that maybe this is the deep problem that we have, because we also right now know the function of the embryo. We can achieve a good embryo in an IVF lab, even with a normal genetic material. But the problem many times is the implantation failure. Okay, and talking about the genetic material of the embryos, you know that if we have a euploid embryo or normal genetic embryo, the possibility for implantation is higher if we compare with an euploid embryo. And this possibility for having a euploid embryo are going down with the aging of the patient. Okay, then, there's an interesting question here. Who decides if the embryo can implant? Will be the embryo or will be the uterus and the endometrium? Okay, this answer remains unclear, but some authors believe that the endometrium could be responsible of 20% of IVF failures. Okay, let's go to the central point of this lecture. What is refractory endometrium? And as I told you before, for having a normal implantation, an optimal endometrium in which to transfer a good embryo are required. This is an essential point. Since ultrasonography became available, both endometrial thickness and the pattern of the endometrium have been intensely evaluated, but unfortunately, there is no agreement about the endometrial thickness. Most clinicians empirically prefer endometrium greater than 7 millimeters, but the available evidence does not support any specific thickness. Some studies, for example, Dr. Remouy, say that similar success have been described from 5 to 15 millimeters. Okay, and what is the definition or the exact definition of refractory endometrium? It's characterized by a lack of proliferative growth response and the absence of increasing in the endometrial thickness. This growing, as you know, can be generated by endogenous or exogenous sex hormones. Okay, then we have a lot of markers for knowing or for analyze the healthy state of the endometrium and the possibility of receptivity in this endometrium. And I want to show you here the markers that we are using today. And in this study published in 2019 for Dr. Krasiunas, you can see here the endometrial thickness, the endometrial volume, the pattern of the endometrium, the blood flow, the contractions, the hydroscopy inspection, the natural killer cells, and the endometrial receptivity array. But if you see here, the thickness continues to be a good marker with a sensitivity of 99%, but with a specificity of only 3%. The other interesting finding here is the blood flow, because if you see here in the left part of the image, this is an endometrium with a very good flow, but in the other side of the picture, this is an endometrium with a very poor flow of blood. Then it seems that the flow on the circulation of the vessels in the endometrium are related with a better implantation rate. Okay, what are the main causes of the endometrial thickness diminish or the refractory endometrium? First of all, the surgical causes: dilation and curettage, partial ablation, aggressive myomectomy, and you must be very careful with this point, post-transplant surgery, radiotherapy, infections, congenital Mullerian anomalies, and idiopathic. Okay, then I want to be very rigorous with this point, because in the routinary practice of any gynecologist around the world, we are practicing dilation and curettage and aggressive myomectomy. But we must consider the consequences and the side effects in the reproduction of the woman with this type of surgeries. Okay, and what is the pathophysiology of this problem? The endometrium theme is caused by a diminished normal endometrial growth. This is an obvious definition, but the angiogenesis plays a key role in endometrial growing and is vital for regeneration and receptive endometrium for implantation. The majority of studies has focused on vascular endothelial growth factor, or VEGF, because the uterine blood flow is an essential marker regulating the endometrial growth. Okay, the ultrasonography has provided new opportunities for non-invasive evaluation of endometrial perfusion. As I showed before in the previous slide, you can see when the flow blood is normal and is good, and it means that maybe that endometrium will be receptive. The reduced pregnancy rate in IVF treatment with low uterine blood flow display this relation between uterine blood flow and uterine receptivity. Okay, and this impaired uterine perfusion is the reason for atrophy of the remaining endometrium due to restricted exposure to circulating hormones. For example, in Asherman's syndrome, like in this picture here. What is the meaning of this? If the vessels are damaged during a procedure, the circulation of the endometrium are going down, or maybe in some cases could lose all the circulation or the blood flow. Then the hormones can't acting into the receptor, and that is the problem, or that is the cause, because the endometrium many times can't grow. Okay, what are the strategies to manage the refractory endometrium? There is a lot of interventions and there's a lot of medications, and I will try to give you a summary about the medical evidence in this type of intervention. Okay, what is the first one? If you consider that we are using estradiol for stimulating the growing of the endometrium and the endometrium doesn't respond, the first idea is, okay, I will raise the dose of estradiol. The main route of estradiol, you know that, is oral. And the first approach is, or I change the route or I raise the dose. But the evidence for this change is very poor in both terms on the rising of the dose and the change of the route of administration. The vaginal route seems to improve the thickness, in according to this study of Dr. Cavanelli in 2012, but not the pregnancy rate. Then the results and the evidence is not strong in this type of change, the estradiol dose or route of administration. The second medication is the HCG injection. You know that this is an hormone that are produced by the implanting embryo and stimulate progesterone production in corpus luteum. But this HCG plays a local paracrine role, very important, regulating different cytokines and growth factors. But what is the evidence that we have in this point? Okay, Prapas in 2009 made this paper, and he used 750 units every third day, but the final result was a thinner endometrium and lower pregnancy rate. By the other hand, Papanicolaou in 2013 used a different dose, 150 units during 1 week, and he found an increasing of the thickness and clinical outcomes, but there is no other studies reported in the literature. Okay, here there is a good intervention with acceptable results until now, and it is sildenafil. You know that this medication has been used worldwide as a vasoactive agent for male erectile dysfunction since, I don't know, maybe 20 or 25 years ago. And the mechanism of this medication is maybe the change in the mRNA, because these changes are responsible for the same effect on rat and human endometrium. And it seems that the sildenafil improves uterine blood flow and leads to estrogen-induced proliferation of the endometrium. Can be applied to patients with a thin endometrium, and it's effective for improving endometrial growth and pregnancy outcomes. Okay, this meta-analysis and systematic review was published in 2020 for Dr. Lee, and in this meta-analysis, finally, they include 9 RCTs or 9 studies, and this was the result. They found evidence that favors the use of sildenafil comparing with placebo. And sorry, here, this is the pregnancy rate with an RR of 1.45, that is good. And the other aspect was the endometrial pattern, that is very important. And it seems that the sildenafil improves the endometrial pattern compared with placebo. Okay, what are the conclusions about sildenafil? It seems that plays a beneficial role in treatment of a thin endometrium, but there are insufficient data. Additionally, little data of live birth rate were extracted from the included studies in this meta-analysis, which may have impaired the analysis of their global results. Okay, 2020, Cochrane Library give us this publication with Dr. Kamat about the use of the granulocyte colony stimulating factor. Okay, and as you see here, it seems that there is a better results when we use the G-CSF comparing with placebo. Okay, but there is a few studies with a small sample size. But the conclusion of this study is that in fertile woman undergoing ART, there is an uncertain whether the administration of G-CSF improves ongoing pregnancy or clinical pregnancy rates compared to no treatment or placebo. Low quality evidence suggests that this administration may improve clinical pregnancy rate in women with 2 or more IVF failures. Okay, there is an intervention that it seems to be useful right now, and is the platelet-rich plasma. This plasma is collected from a peripheral vein through activating platelets will release cytokines and growth factors, including VEGF. And as you know, the VEGF could improve the growing of the endometrium. PRP has been shown to play a role in tissue regeneration, angiogenesis, cell migration, and cell proliferation. There are numerous methods of preparation for PRP, from blood collection to commercial kits, and maybe this is the problem that we have in this intervention, because there is a lack of a standardization in the technique of the preparation of this plasma, and maybe that affects the outcomes and the reproducibility of the studies in the analysis. Okay, in 2021, Dr. Sharada made this publication, and he gave us the summary of the studies using PRP in cases of thin endometrium. And if you see here, we have only one RCT, and the other studies was retrospective cohorts or case reports. Then only with this slide, you can conclude that the evidence is not very strong in this point. Okay, there are limited literature shows promising increasing, it seems, in the endometrial thickness and levels of AMH and the chemical and clinical pregnancy rates. The lack of standardization in the preparation method and the lack of RCTs needs to be addressed in future studies, definitely. But until now, the results seems to be promissory, and anyway, you can use the PRP, but it should be considered until now as an experimental intervention. Okay, what about the stem cell therapy? You know that there is a lot of groups working in this type of therapies, and the cell therapy is one of the most effective fields of translational medicine. You know that possesses the potential to turn into a novel therapeutic platform for treating a wide range of clinical disorders. These cells are capable of dividing into pluripotent and multipotent stem cells with some advantages and disadvantages associated with their utilization. There are different ways for obtaining the stem cells: mesenchymal, extracellular vesicles, bone marrow, and others too. Okay, this is a good research published with Dr. Garbi in 2022, just a few months ago, and Theodoric give us the idea that growth factors could improve the endometrial thickness just for the stimulation of the cells around the endometrium. It's not important, or it's not a big deal, the origin of the cell. Maybe the final effect will be the same. There's other publication, but this is a comparison between autologous versus allogenic use of this type of cells, and it seems that there is evidence that give us a better results when we use allogenic cells, and maybe it's the same results in oncology and other diseases. Until now, the evidence shows that maybe it's a better option using allogenic cells and no autologous cells. Okay, despite the advances in this field, major concerns still exist in this point. And the problem is that these cells are associated with the pathogenesis of many gynecological diseases, for example, endometriosis, endometrial hyperplasia, and even endometrial cancer, are capable of stimulating angiogenesis through the secretion of growth factor, but it could be an effect in benign cells or in cancer disease. And these novel therapies could have numerous advantages over traditional therapies, but maybe there still exists a place for improvement. Other researches with more patients and more results for be calm or be sure about the safety of this intervention. Okay, the uterine transplantation obviously is an option. In my opinion, maybe it could be the final line that we could consider, but there is an important experience in the world. This review was published the last year, and they give us the information of 65 patients around the world with uterine transplantation. Obviously, not all of them with refractory endometrium. Maybe there's a lot of patients that lose her uterus during surgeries or radiotherapy or other even congenital problems. But you must know that this uterine transplantation could have complications and side effects in the donor and in the recipient. Then we are in that line, but I feel that maybe in some years could be interesting option. Okay, it's a new approach of absolute uterine factor infertility. There is a significant clinical demand for uterus transplantation around the world. Should be considered a clinical experimental procedure. Okay, there are other strategies with a low quality of evidence. For example, the aspirin use, the vitamin E and pentoxifylline, the nitroglycerin, the L-arginine, but unfortunately, no one of these interventions has good evidence quality. Okay, the use of GnRH analogs described by Kuhlmann in 2008, it seems that there is a benefit effect in small size, and there is no other studies about this theme, and the hydroscopy. And you must be very, very careful with this point, because the hydroscopy is absolutely useful in cases of cavity abnormalities. For example, if we have a fibroid, if we have a septum, if you have Asherman syndrome that you could correct by hysteroscopic intervention. In these cases, hysteroscopy is a good option, but not in the pure thin or the pure refractory endometrium. And there is other option. The uterine transplantation could be the last line, but in my opinion, the surrogacy process could be in the same line or even before uterine transplantation. The surrogacy are a process very common around the world, and just 1 week ago here in Colombia, in our Fertility Society, we made a document with all the recommendations that we consider are the ideal way for practicing this process. Okay, this is a summary. It's very good review published 3 years ago, and you can see here the problem that we have, and is that there is a lot of studies combining different methods. For example, these studies are combining estradiol, HCG, and GnRH analogs. Then there is different regimens, different doses, different moments, and this is a real problem for extracting good evidence. In these studies are combining sildenafil, aspirin, pentoxifylline, and neuromuscular electrostimulation. And if you see here, every study has a different protocol. And this is the problem because there is no standardization about this process. And finally, we are going to this way, the use of PRP and the use of GCSF. But again, if you see here all the studies, the protocols are very different between one group and the other. Okay, what are the interventions or the strategies that we could use in these cases? This is the list. The green only in hydroscopy, but remember that this green is for patients with cavity abnormalities. But there are 3 interventions that it seems to be very, very promising or promissory for improving the endometrial thickness. The use of PRP, the sildenafil, and the cell therapy. In my opinion, after this deep revision of the reviews of the literature, I believe that maybe these 3 interventions could be useful. Okay, what are my conclusions of this lecture? The endometrial receptivity is a complex process that involves a lot of mechanisms, molecular, biochemical, immunological, and others. The window of implantation has an accurate moment and precise moment in both in vivo and in vitro conditions. The implantation requires a good quality of embryos and a good endometrium too. The refractory endometrium is a real challenge in reproductive medicine and is related with low implantation and pregnancy rates in IVF cycles. There are specific factors related with the refractory endometrium. It seems that exists a relation between the lack of blood flow and the thin endometrium. Some strategies have shown efficacy for improving the endometrial thickness. The available evidence is controversial and based only on a few RCTs. Sildenafil, platelets-rich plasma, and cell-based therapy are promissory interventions and maybe the interventions with acceptable evidence until now. And finally, uterine transplantation and surrogacy are alternatives to consider in this type of cases. Thank you very much for your attention, and I hope that this information will be useful in your veterinary practice. Bye-bye.